Welcome back. In this video, I will discuss a very important topic, systemic sclerosis, also known as scleroderma. It is an autoimmune connective tissue disorder that is characterized by fibrosis, that is thickening of the skin, and also there is fibrosis of the internal organs like lungs, kidneys, and also heart. Pathophysiology. There is actually autoimmune activation leading to production of autoantibodies, for example, anti-centromere antibodies seen in limited type and anti-SCL70 antibodies seen in diffuse type. So when these antibodies are produced, there is endothelial injury leading to vascular narrowing and ischemia. Also, there is activation of the fibroblasts that lead to fibrosis, that is deposition of excess collagen and fibrosis of skin and organs. So it results in production of autoantibodies that lead to endothelial injury and fibroblast activation leading to fibrosis of the skin and organs. Types. It has two main types: limited disease and diffuse disease. Limited cutaneous systemic sclerosis, as the name indicates, there is limited skin involvement, especially distal to elbows and knees, and there may be involvement of the skin of the face. And it has a characteristic syndrome known as Crest syndrome. C stands for calcinosis cutis, R stands for Raynaud, E stands for esophageal dysmotility, S stands for sclerodactyly, there is flexion deformity of the fingers, and T stands for telangiectasia. Calcinosis, C calcinosis, R Raynaud, E esophageal dysmotility, S sclerodactyly, and T telangiectasia. This is Crest syndrome. Crest syndrome, typical of limited systemic sclerosis. Diffuse cutaneous systemic sclerosis. There is diffuse involvement of the skin proximal to elbows also and proximal to knees also. There may be trunk involvement too. Early visceral involvement is seen in diffuse systemic sclerosis like lungs, leading to interstitial lung disease and pulmonary hypertension. There is also involvement of the heart leading to heart blocks and also myocardial fibrosis. There is also involvement of the kidneys leading to scleroderma renal crisis, in which there is hypertensive crisis due to intimal proliferation of the arterioles in the kidneys. Clinical presentation. Skin. There is thick, tight and shiny skin. Face is mask-like. There is sclerodactyly. The fingers are tapered at the ends. Digital ulcers are seen because the blood flow to the skin is decreased, leading to formation of digital ulcers, and later gangrene formation can also be seen. There is calcinosis, deposition of the calcium in the skin. Hypo or hyperpigmentation is also characteristic. It is also known as salt and pepper skin. Sometimes somewhere there is hypopigmentation, somewhere there is hyperpigmentation. Then vascular. Raynaud's phenomenon is most often seen in the systemic sclerosis. It leads to initially paleness of the fingers and then cyanosis and then redness. This redness is characterized by pain in the fingers. So this is Raynaud that is mostly seen in the systemic sclerosis. There may be telangiectasias and nail fold capillary changes. Now we come to gastrointestinal. These include dysphagia and reflux of the gastric contents into the esophagus because of esophageal dysmotility, leading to esophageal fibrosis. There may be malabsorption because of small bowel involvement, leading to small bowel hypomotility and bacterial overgrowth also. These both things can lead to malabsorption, in which there is constipation and diarrhea alternating with each other. Pulmonary. As I have told you, there is involvement of the lungs leading to interstitial lung disease and pulmonary arterial hypertension. This can lead to cor pulmonale, that is pulmonary arterial hypertension leading to right-sided heart failure, cor pulmonale. Then renal involvement. Scleroderma renal crisis. It is actually characterized by malignant hypertension and acute renal failure. As I have told you, scleroderma renal crisis is seen in diffuse disease. Cardiac involvement. Arrhythmias like heart blocks, pericarditis, and myocardial fibrosis. Diagnosis. You can diagnose it clinically and by laboratory findings. ANA is positive in almost all of the cases. While anti-centromere antibody is present in the limited type, and anti-SCL70 antibody is present mostly in the diffuse type but can also be present in the limited type. But anti-centromere antibody for limited type, anti-SCL70 antibody for this diffuse type. Sometimes there is presence of anti-RNA polymerase 3. When it is present, there is increased risk of renal crisis and also solid organ tumors like breast carcinoma. HRCT test should be done to diagnose interstitial lung disease and you should manage for it then. Echocardiography shows pulmonary hypertension. MRI of the heart can also be done. It shows fibrosis. RFTs should be done that show acute renal failure, and BP monitoring to determine if there is scleroderma renal crisis. Management. First we do general measures because there is no treatment for the actual management of this disease, but we go for according to the symptoms. General measures include avoid cold exposure for Raynaud's, regular skin and joint care, and stop smoking because you already have interstitial lung disease. Raynaud's phenomenon. For Raynaud's phenomenon, as most of you know, calcium channel blockers are first line like nifedipine, amlodipine. But if these don't work, then PDE5 inhibitors like sildenafil are also given. These both can help in also pulmonary hypertension. IV prostacyclin for severe cases can be given. It also helps in pulmonary hypertension. Skin fibrosis. For skin fibrosis, if there is arthritis also, then methotrexate is good option. If there is also arthritis, then methotrexate is a good option for skin fibrosis. And if there is interstitial lung disease, then mycophenolate mofetil is a very good option. Cyclophosphamide is reserved for refractory disease, especially progressive disease. Pulmonary involvement. If there is interstitial lung disease, mycophenolate or cyclophosphamide is given. And sometimes for pulmonary arterial hypertension, endothelin receptor antagonists like bosentan and PDE5 inhibitors like sildenafil, vardenafil, tadalafil can also be used. Other agents like prostacyclin analogs like epoprostinol, treprostinil, and prostacyclin can be given. Prostacyclin can also be given for this condition. So, for pulmonary arterial hypertension, you can go for endothelin receptor antagonist, bosentan, PDE5 inhibitors like sildenafil, and also prostacyclin analogs like epoprostinol and treprostinil, etc. Then for renal crisis, as it has malignant hypertension, you should go for captopril, and it is given initially as 25 milligram per oral QID 4 times daily, and you can increase this dose to 100 milligram QID. Strict BP monitoring is required in case of renal crisis. For gastrointestinal problems, these are very bothersome. Proton pump inhibitors for reflux are used. Furthermore, patients should be advised to take meals at least more than 2 hours before going to sleep. So it also decreases reflux. Furthermore, prokinetic agents can also be given for motility like metoclopramide, cisapride, and an antibiotic is also given, that is erythromycin, that has prokinetic activity. Prognosis. It depends mainly on the type of the disease and the organ involvement. If there is more early pulmonary and renal complications, then it is the main cause of mortality and prognosis is poor. But if this involvement occurs later, more than 3 years after disease onset, then prognosis is good. Early diagnosis and immunomodulatory therapy improves the outcomes. So this is all about systemic sclerosis.